very good day to all of you. I am Dr. Lahari here, and today we will be discussing about differential diagnosis. This is the last chapter for
Right, so let's just go through the course learning outcomes of oral medicine and radiology since we've come to the end of the course.
Revise for the
So at the end of 2 years of learning,
you are expected to acquire knowledge and basic understanding of disease process and apply it to diagnosis of diseases affecting the oral cavity and jaws, identify the oral manifestations of systemic diseases, and be able to plan the dental management of medically compromised patients, understand the basic principles of diagnostic imaging, radiation safety, and apply them to the production of dental images, detect and interpret dental and osseous diseases, and have knowledge of radiographic manifestations of systemic diseases. And I'm pretty sure that after all of the learning, teaching and learning, I'm sure you are able to do all of these. So when we're talking about differential diagnosis, we generally give it for these two areas, that is mucosal lesions and oral radiology. So in the mucosal lesion sections, it could be an ulcer, a growth or swelling, white lesion, red lesion, mixed lesion, pigmented lesions, and few others. In radiology, it would be for a radiolucency, differential diagnosis for an opacity or mixed lesion, or again some anatomical variants which could mimic one of these. Let's look at ulcers first, the simplest and most easiest or most commonest one. So when you're looking at a case which comes to you or presents to you with an ulcer, for example, here you can see two diffuse ulcers. What are the most important features that you need to jot down? So those are listed down here. That is, first of all, the site and the location, the size, the number of ulcers. For example, here you're seeing that there are two ulcers, but they are very ill-defined. You can't really make out the boundary. Looks like they are merging into the normal tissue, but they have a redness around them. And look at this ulcer here. These looks like ruptured vesicles, and there is an ulcer formed here, but the rest of them are probably still forming into ulcers. So the shape, margin, whether the lesion is preceded by a vesicle. What about the healing time or the recurrence? Presence of associated symptoms like pain, fever, is there any systemic manifestation, and the effect on adjacent structures. So all of these points put together will help you arrive at a diagnosis. So this is essentially a combination of history and the examination that you do. So first you take a history, then you do an examination, and by the end of it, in your mind, you must be already thinking of a diagnosis or multiple diagnosis, which forms the differential diagnosis. So I'm sure you've already come up with some diagnosis looking at the location and the number of the ulcers here, as well as these ulcers over the upper lip. And yes, you're right, if you've thought of traumatic ulcer here, and you've thought of a herpes labialis, which is crusting, probably preceded by a vesicle. Now, ulcers can also be categorized based on their margin. So if you're having a nice well-defined margin here like this, or an irregular ulcer like this, it will be easier for you to give a differential diagnosis. So this again may look like an aphthous ulcer, whereas these multiple irregular ulcers, you could think of traumatic ulcer, and this deep looking ulcer here, and the site on the tongue will give you the suspicion that it could either be a traumatic ulcer or it could be a malignant ulcer. Next, let's move on to growth. When we're talking about growth in the oral cavity, there are some images that come to your mind. So these are some of the common images which I have displayed here. Again, it's important when you're looking at a growth to look at the site or the location, the size, the number of growth or growths that you're seeing, size, shape and margins of the growth, progress. Is it slow growing or is it recurring? That means it goes off completely and comes back again. And presence of associated symptoms again. Is it associated with any sort of pain, fever, or systemic manifestations? And nextly, the effect on adjacent structures. What has it done to the area around it? Is it pushing some structure, or has it grown around the structure? For example, around the tooth, right? So the example here that we are seeing is very clearly an edentulous arch and a sort of wedged appearance. One area looks very sharp here and the other looks smoother, giving an appearance that probably this is related to the denture that the patient is wearing, and hence this is more likely to be an epulis fissuratum, arising because of an ill-fitting denture. Chronic irritation from the denture gives rise to this hyperplastic growth. Moving on to this picture, you're seeing a more well-defined, rounded and smooth growth on the buccal mucosa. Whenever you're looking at a more smoother growth, even though you know it is hyperplastic in nature, we would like to term this as a fibroma clinically rather than a fibrous hyperplasia. Both of them are similar in origin, probably when you do a biopsy, but clinical examination, this is given a more rounded and smooth appearance, and hence the term fibroma. In this picture here, there are rather confusing growths. You see multiple growths that are visible here. So when you're looking at this sort of a picture, the idea or the differential diagnosis cannot be something very simple like a fibrous hyperplasia or a fibroma. You should think of something more which is different than the etiology that has given rise to these lesions. So it could probably be viral in origin, and these growths, which are so irregular and atypical, could be a viral wart like a condyloma acuminata, and hence it very important to assess the systemic condition of this patient or the underlying disorder that the patient is suffering from, and hence some blood investigations and more investigation might be required for this patient. Gum swellings. Gum swellings, again, you can group them down, narrow them down based on the history and the appearance of the swellings. Again, site or location, the size, the number, the shape and the margin, how are they progress, slow growing or recurrent, and presence of associated symptoms, pain and bleeding also, and of course the effect on adjacent structures. When we're talking about adjacent structures, we specifically mean the teeth and the bone underlying. What has it done to that? In these pictures, you're seeing again gum swelling. One of them looks irregular, one of them a little more regular and erythematous. So there are some diagnoses that must be already going on in your mind. Again, looking at the rest of the gingiva, because it looks quite normal, only one particular area is affected. So this could be due to local factors and hyperplastic growth of the gingiva, or a more specific diagnosis like a pyogenic granuloma if there is pregnancy or other features of trauma involved. Moving on to white lesions. Now, white lesions for a novice dentist or a student may sometimes be confusing. You already have a number of white lesions running in your mind, and you suddenly a patient's photograph or a patient is in front of you and you're expected to give an accurate diagnosis. So at that point, again, giving differential diagnosis, keeping certain criteria in mind can help you arrive at the diagnosis. The things that you need to remember again is a combination of history and examination, which would be site and location, size of the lesion, what is the extent of the lesion, is it unilateral or bilateral, how is it progressing, slow growing, is it recurrent, right? And the presence of associated symptoms, like for example, is it associated with burning sensation. Now, I have not listed out fever and pain here because generally white lesions are not associated with fever. They will be more likely to be associated with burning sensation. Whether they're scrapable or not, very important point. And whether they're thick or thin in appearance. Now, this thick or thin may sound like a layman term, but when you're looking at clinical picture of these lesions, a more dense or area with more keratinization is referred to as thick, and a more reasonably thinner area is the one where there is a lesser amount of keratinization. So looking at the images here, again, based on the location that you're seeing these lesions, you would be having certain differential diagnosis running in your mind. Probably this one looks like leukoplakia, but why is it so widespread, and why are there areas which are looking hyperplastic? So a PVL should also be in the differential diagnosis. Looking at this lesion in the vestibule, again the classical example of tobacco pouch keratosis should come to your mind, as well as leukoplakia. And tobacco pouch is not a potentially malignant disorder, but leukoplakia is. But in this image, both of them look alike, so they could form differential diagnosis based on the location of this lesion. Coming to the lesion on the tongue, again a white patch seen, more like a plaque seen on the lateral border of the tongue, posterior lateral border. You could think of a leukoplakia as well as frictional keratosis as differential diagnosis. So that is how you form differential diagnosis, essentially based on how the lesion appears and a combination of all of these factors put together. When there's a mixed appearance of red and white lesion, the differential diagnosis becomes a little more trickier because you have more diagnosis that could be part of the lesion, differential diagnosis. So the image that you're seeing here is that of a tongue. Keeping in the points that we had covered previously, what you're seeing here is a diffuse redness on the dorsum of the tongue with a few patchy white areas. So when you're looking at the dorsum of the tongue, midline, redness, again, median rhomboid glossitis or some form of candidiasis should come to your mind. Coming on to this picture here where you're seeing striae. As soon as you see striae, lichen planus should be part of your diagnosis, right? So other than lichen planus, which are the lesions that also have white lesions with a central erythema? Could be an SLE or a DLE, or a lichenoid reaction because you're only being shown one side of the cheek or buccal mucosa. This image here is again rather confusing. You can see that there is an ulcer here, an irregular ulcer, but there's also thick coated white tongue and some irregular red and white areas. So as soon as you see that there's an ulcer with irregular red and white areas, your thought process should go towards ulcerative vesiculobular disorders. So right from having said that, it's also bilateral, that means on both sides of the tongue. So you should be thinking of pemphigus, pemphigoid, bullous lichen planus and similar diseases. So if you had given median rhomboid glossitis for this, you would be going wrong because you've missed this ulcer which is seen here. Pigmented lesions. Pigmented lesions, again we have a few diseases which you need to remember, and it would revolve around that some more or less. So if you're looking at images here, which is pigmented grayish blue area associated with amalgam, then the question of amalgam tattoo, should arise. Whereas in this case, there you can't really see amalgam. Probably this is a PFM crown. You can't really make out very well. And then you're looking at the grayish blue areas somewhere at the atagingiva region. So this could be retrograde amalgam, which is visible through the layers of the mucosa, or you could also think of it as a nevus, which is a differential diagnosis. Moving on to these set of pictures, the pigmentation is more diffuse and more multiple lesions. Again, keeping the same points in mind: site, location, the size of the lesion, the number, and whether it's bilateral or unilateral. Looking at this, you can see that there's patchy distribution of pigments all over the buccal mucosa and the tongue. So this probably is leading you to believe that there could be some systemic cause or underlying hormonal imbalance which could be leading to this pigmentation. Head and neck swellings. When you're talking about an extraoral swelling, the list of swellings again in the head and neck region could be a huge list, but there are some important things you need to keep in mind. Again, the site and the size of the swelling and the consistency of the swelling, whether it is soft or firm, how long has it been there, is it acute or chronic. So that gives you an idea that it has to lie somewhere around these areas. So generally the soft to firm swellings could be abscesses enlarged lymph nodes, enlarged salivary glands, if they are in the location of salivary gland. For example, the one that's shown here with the yellow arrow mark pointing towards an enlarged submandibular salivary gland. If it could be a soft tissue cyst, if it is located in that area, again could be probably a soft tissue cyst, a tumor or muscle or nerve origin tumor. If it's a heart swelling, it could be a cyst or tumor arising from jaw and bones. For example, the swelling that is seen in the cheek here of this patient could be an amyloblastoma, for example, or even this, which is arising from the maxillary sinus area here, obliterating the ala of the nose, giving you the idea that it could be a swelling arising from the maxilla or the sinus itself. So that is how you come about with differential diagnosis of head and neck swellings. It is a long process, and there are quite a few key factors that you need to keep in mind, right? Most important is the location, size and consistency of the swelling, as well as duration. How long has the swelling been there? So as soon as you know it's an acute swelling, you would narrow it down to an abscess or a lymph node enlargement, even probably a salivary gland. But you would not think of it as a cyst or a tumor, which takes some time to manifest. So that is an important method of how to arrive at differential diagnosis of swellings. When it comes to an intraoral swelling, again very importantly, you need to look at the site and the location, size, number, margins, consistency. Is it soft, firm or hard? Progress is it slow growing? Is it recurring, right? And is it associated with fevers, pain or systemic manifestations? And what has it done to the adjacent structures? So these are some examples of swelling again, which are seeing a swelling obliterating the buccal vestibule. Probably one of these teeth is the cause of the swelling, and if it is soft in consistency and acute in nature, you know you're looking at a dental abscess, right? A dentoalveolar abscess or a periapical abscess. Let's come to this picture here, where you're seeing a swelling seen in the attached gingiva, again probably extending to the vestibule. What you need to look out for is there any tooth missing? Is it probably an impacted tooth, or is it a cyst arising from that part of the jaw, right? So coming to this picture here again, the arrow marks are pointing towards the swelling, which is on both sides of the arch. It's seen extending onto the buccal surface, obliterating the buccal vestibule of the maxillary arch, and as well as a palatal swelling. So again, if this is an acute swelling, then you should probably look at this tooth if it is decayed and giving rise to an abscess which is extending onto both sides, right? So that is how you come about with a differential diagnosis based on the location, the number of swellings, consistency, and the progress or duration. How long has the swelling been? So if you're looking at a swelling that is acute, it would not be right to give a diagnosis of an amyloblastoma or a cyst or a tumor, because they take a considerable amount of time to grow, and they cannot generally be soft and would not generally be associated with fever. Moving on to radiographic differential diagnosis. What we've seen so far were clinical differential diagnosis. So when we're talking about radiographic differential diagnosis, it is important that when you are doing radiographic diagnosis, you have an idea of the history or the clinical picture in mind. Very rarely you are asked to do radiographic diagnosis in dentistry without the clinical picture in mind. So they go hand in hand, and it will be very difficult for us to arrive at a final diagnosis if we don't combine imaging with history and clinical findings. So what do you analyze when it comes to radiographic differential diagnosis? The site, the number, whether you're looking at a solitary lesion or multiple lesions. Shape and borders give a very big clue as to what type of lesion you're looking at. Internal structures, whether it's completely radiolucent, completely radio-opaque, or mixed. And again, what has it done to the structure surrounding it? So these are some of the important things that you keep in mind when you're analyzing any radiographic lesion. Let's look at this example of radiolucencies which are well defined versus radiolucency which is ill defined. The image here is showing you two central incisors which are root canal filled, and there is a nice rounded well-defined radiolucency which is arising from both the roots or engulfing both the root apices of these teeth. So when you're looking at a well-defined radiolucency associated with probably a tooth which is pulpally involved, you should think of in terms of a periapical cyst. If you are saying granuloma, you may not be right because this is already looking like 2 cm in size, so it cannot be a granuloma, right? So next is looking at this well-defined, ill-defined lesion, sorry. Okay, you're looking at the apex here, which looks like a blunderbuss canal. So definitely there's an open apex here, and there is an ill-defined radiolucency in this tooth which is carious. So that gives you a very clear clue that this carious lesion has led to this ill-defined radiolucency, and probably this is an abscess. But what about this tooth? It doesn't seem to be involved pulpally, and yet the root apices have not formed. So probably this person or child must still be in the process of apexification, and this vague radiolucency that you're seeing here could, pointed with this green arrow mark, could be the mental foramen. So that's how this can be a little confusing. And if you were to actually clinically differentiate these, you might have to test the tooth for vitality or take another image by using a buccal object rule. That means taking a shift radiograph to see if this radiolucency actually moves. If it does, then you know you're looking at the mental foramen. So defining the borders that's why important to get to the diagnosis. So if you have nice well-defined borders, for example with an impacted tooth, and this looks like a maxillary canine, you have very few lesions that come to your mind. First of all, a dentigerous cyst, AOT, or a OKC, right? So you may have more examples, but I've just quoted few of them. Now looking at this radiolucency here, nice and well defined again, but there's no tooth involved and there's no structure inside. So you must think of a residual cyst for this sort of a radiolucency. Or you could also think of a lateral radicular cyst affecting this tooth which has a bridge. Again, similar lateral radiolucency, but much higher, not at the apex, so could be a lateral periodontal cyst or a lateral radicular cyst. Right? Similarly, here also seen on this adjacent to the premolars, between the roots of the premolars, giving an appearance of probably a lateral periodontal cyst or a lateral periapical cyst. Multilocular lesions, this is an example of an OKC, large, destructive, and having multiple locules. Also, you could think of an ameloblastoma because there is an impacted tooth involved, and dentigerous is less likely because it generally doesn't have so many locules, but nevertheless, you could think of a differential diagnosis. That's how you arrive based on the location, size, presence or not of impacted teeth, and what it has done to the adjacent structures. When you're talking about well-defined radio opacities, you have a picture of a nice radio opaque odontome here, which is obviously the cause of the canine not erupting on time. Maybe yes, canine not erupting on time, and the lateral has been displaced. So also there is a radiolucency around the canine, but again, since the width of the radiolucency looks within normal limits, this could be a normal follicule, whereas this looks like an odontome. Similar appearance of radio opacities here seen at the apex of the lower incisors. You should generally think of a periapical cemental dysplasia because multiple teeth are involved. When we're talking about ill-defined radio opacities, again, this looks like a diffuse area of opacity seen in the maxillary sinus area and extending onto the buccal surface. Similarly, even here, a diffuse ground glass-like appearance, all belonging to similar cases, which is of fibrous dysplasia. Again, diffuse patchy radio opacity is ill-defined. You can't really determine the boundary, and it looks like it's blending into normal bone. So this is also ill-defined or a mixed appearance, ground glass-like, and it appears to be merging into normal bone, but you know that it's restricted to this 5 by 5 cm area, which could be a cement-ossifying fibroma. So when you're looking at differential diagnosis, you have to think from multiple points of view. You need to have a sound knowledge of, or a bank of diseases that you make in your mind with images which are already in your mind. So it's important to keep looking at multiple images and keeping them in your mind, so that when you're looking at an image in the exam or in the patient's mouth, you already have a list that's running in your brain. So some tips for OSCE preparation would be, first of all, don't panic, right? It's important to keep your cool. When you're keeping your cool, your mind thinks better, it opens up, and then a lot of ideas from the back of your mind come forward. So self-induced anxiety is the worst enemy. Practice time management. So OSCE is all about time management. It's you've seen the picture before, or you know that this kind of lesions exist. It's just that you're too packed with time, and then you waste all your time answering only one question. That's not how you do it. You need to space yourself. So the best would be to practice it. And how do you practice it? Is to get a stopwatch and a couple of friends and do make OSCEs for each other. And like I said, the point number 3, make up scenarios for each other and practice it. That's the best way to work an OSCE out. And read the question. Very importantly, you are in a hurry to answer the question and you forget few bits of the question. You read only part of it and you jump to answering it, and you might actually get the question answer wrong. For live stations, communication is very important. Keeping your cool is again very important. Smile, eye contact, take the hint from the patient, because the patient is communicating. He or she might be throwing away hints, and if you're not taking the hint, then you won't be heading in the right direction. And don't get stuck with a tricky question. Move on. Even if you've got it wrong, is okay. You might get the part of the answers right. So don't let that wrong diagnosis or one tough station bring your morale down. And lastly, don't cheat, because it won't take you anywhere. And the best of the best students sometimes make mistakes in OSCEs. So it's important to keep your cool, and you will do well. So that's it from my side, and this would be the last lecture for oral medicine and radiology. If you have any doubts, please don't hesitate to ask us. We're always here to answer your questions. Please feel free to drop questions in the comments, or you can drop questions on the e-portal, or just text me. Thank you. I've just left a note here for all of you.